Healthcare in America versus socialized medicine today. 1. What we have now, U.S. model. The U.S. system is a hybrid multi-payer system, private insurance, employer-based and individual market, public insurance, Medicare, Medicaid, TRICARE veterans, health administration, private hospitals, mostly nonprofit, some for-profit, private physician practices, increasingly consolidated. Important reality. Roughly half or more of U.S. healthcare spending already flows through government programs. We are not a pure market system. We are a complex blend. 2. What socialized medicine actually means. People often use socialized loosely. There are actually 3 different models internationally. A. Fully socialized. Government owns and employs. Example: National Health Service in the UK. Government owns hospitals. Doctors are government employees. Government sets budgets directly. Care funded through taxes. That's true socialized medicine. B. Single payer. Government pays, private providers deliver. Example: Medicare, Canada's system. Private hospitals and doctors. Government is the main insurer. One public payment system funded via taxes. This is not government-run hospitals. It's government-run insurance. C. Multi-payer regulated system. Example: statutory health insurance, private and non-profit insurers. Strict national rules, price controls, universal coverage mandate. 3. So, how different are we? Structurally, we already have heavy government financing. We already regulate pricing in public programs. We already operate large government-run care systems, VA hospitals. We already subsidize private insurance through tax exclusions. What we don't have: a unified payment structure, national price controls across the board, universal automatic coverage, simplified billing. The biggest structural difference isn't just who pays, it's fragmentation, administrative layering, pricing freedom in private markets, employment-tied insurance. 4. Where the real divide is. The debate isn't simply private versus socialized. It's about who controls pricing, how risk is pooled, how incentives are aligned, how much administrative complexity is tolerated. Even a socialized system still rations care, just differently, wait times versus cost sharing. Even our current system has price controls, just unevenly applied. 5. If the U.S. moved towards socialized, what would actually change? Not necessarily hospital ownership. More likely changes would include centralized bargaining power, uniform reimbursement rates, elimination of employer-based insurance, tax-based funding instead of premium-based funding, dramatically reduced administrative overhead, reduced insurer role, the money flow changes, the power centers shift, administrative structure simplifies, but doctors would still practice medicine, hospitals would still exist, care would still be rationed, just through different mechanisms. 6. The quiet truth. We are already halfway between models. The U.S. system is not a free market. It is not socialized. It is a layered hybrid with competing incentives. The question isn't, would we become socialized? The real question is, how centralized do we want payment and pricing authority to be? That's a structural debate, not just a funding debate. To go deeper, we have to explore what would actually happen to costs, what happens to innovation, what happens to wait times, or what a realistic transition would look like. The real questions aren't ideological, they're mechanical. How do you unwind employer-based insurance? What happens to 150+ million people currently covered through work? How do you transition provider payment rates? What happens to hospital revenue if Medicare rates become universal? How do you fund it? Payroll tax? VAT? Income tax? What happens to innovation incentives? What happens to wait time management? What happens to administrative jobs? How long would the transition take? 5 years? 10?